Welcome everyone to Milan. Thank you for the privilege and opportunity to speak about this subject. My disclosures are noted here. A couple of things. This talk has no involvement from industry. And the most important disclosure is that I use both the Moses holmium laser and the thulium fiber laser in my clinical practice. Our world is full of choices. Do you want an iPhone or do you want an Android Samsung? Is LG TV better than a Samsung TV? And our family had to undergo that research a couple of months ago. So which laser do we use in 2023 for stones? Well, we have the holmium laser, and now with the advanced multi-pulse mechanisms with Moses technology and virtual basket from Quanta, these are very attractive platforms. But we also have the thulium fiber laser, initially with the Saltive from Olympus, and now many other companies have released thulium fiber lasers. So we are spoilt for choice. How do you choose? Well, you need to understand the differences so you can select the right laser for the right job. And on Monday, Dr. Cho, Dr. Higgins from our group at Michigan will be presenting a video on this. So if you'd like to have more information on that, please watch that video. But today I'm going to focus on a single case. And for me to focus on that, I need to explain to the audience the differences between holmium and thulium fiber laser. Number one difference for holmium is the holmium has high peak power, at least 5 times more than a thulium fiber laser, which means it is excellent for fragmenting. It can crack, it can chop, and it can work at distance. Thulium fiber laser has low peak power. It's good at dusting, small chops, but it's also really good at incision, and it's very hemostatic. Holmium is Bruce Lee. This is Bruce Lee against Joe Louis. Look at his punch. High peak power, retropulsion. This is an impacted stone in the ureter in one of our patients who's actually one of our urology residents and was treated with 1 joule using the Moses. Holmium is Bruce Lee. Look at it. It cracks. It chops. Thulium is my daughter. And that's the person you see in the middle. Watch this.
All right, students, are you ready? Yes, sir. Instructors, are you ready?
Yes, sir.
Roll strong punch. Ready? See, shot. Two hands.
Yep, it's a calcium oxalate monohydrate stone. Thulium gives you little chops. It's got low peak power. Look at 1 joule at short pulse on that stone. No cracking, very gentle. It's a good thing in the right scenario. What does this mean globally for us as urologists in the modern day? 60% of all stones that we treat is in the ureter. So what? Many of those stones can be impacted, and their high peak power can really matter. It can be the difference between an easy or a difficult operation. But sometimes urethral stones can surprise you. So let me tell you about a difficult situation we faced in Michigan. This is the patient's story. 33-year-old female, referred by my colleague, intermittent left-sided flank pain. She had been to the emergency room 4 times in 4 months just before she'd seen me. And she'd been diagnosed with a left upper urethral stone, 6 millimeters. Her problems began in March 2017. She had an obstructing stone and sepsis and was actually in the ICU and ventilated and had to undergo an emergency percutaneous nephrostomy placement, which was complicated and extravasation occurred. The tube was eventually placed, but the stone still remained in the upper ureter. A month later, she underwent ureteroscopy in our facility, where it was noted that the ureter was tortuous with a kink, but there was no stone in this area. No stone in the ureter. She had recurrent left-sided flank pain. She was diagnosed with fibromyalgia. She had 3 ureteroscopies after that one, all negative, cannot find the stone. Like I said, she'd been in and out of the emergency room in pain. She was always told, the CT says, left upper urethral stone, 6 millimeter. When she was seen in my clinic, we then discussed it at our endourology case conference, and we discussed what is the best management. Is it reconstruction? Is something needing to be done? So this is the CT at the time. You can see 6 millimeter upper urethral stone. We got a CT urogram, and this shows that the stone is adjacent and anterior to the non-dilated left ureter, which could represent a small extruded calculus. So I took it to the operating room with the plan that maybe the stone is embedded in the ureter, and maybe we need the right laser for the right job, and maybe for this particular patient, they need a thulium fiber laser. So now I'm going to play this video, and now this is the opportunity for Dr. Giusti to ask questions as we go along. But as you see, this is the upper ureter here, and then you see a redness, and then on fluoroscopy, that's consistent with the stone. A little technical point which I got from Dr. Traxer. I used the 150 fiber, but I found that it used to get stuck in the working channel, and Olivia told me, cut the tip. So since I've been doing that, I can get the fiber in pretty easily. And you can see here the 150 fiber, and I'm using a setting of 1 joule and 2 hertz. And I'm cutting at that area where there's no obvious stone, it's just some redness. And I'm cutting at 1 joule and 2 hertz. And this is a setting I got from Dr. Mantu Gupta at Mount Sinai. I'm cutting, and I'm asking myself, what am I doing? Where is the stone? So we keep going, and some of the video is sped up just so we can get through it in appropriate time. And you can see here that now, maybe there's something yellow that's coming into view. But we also know that sometimes you get this yellow charring when you cut the ureter with the laser. So is that really stone? I'm now incising the ureter. Again, I haven't changed my settings. For this whole case, it's 1 joules and 2 hertz. And that's something quite unique with these thulium platforms, is that you can get the pulse repetition really, really low. Holmium, you can only get to 5 or 6 hertz. But with thulium, you get to 2 hertz, and that gives you quite a lot of control. And now we're seeing a little bit more appearance of possibly a stone. Does that look like a stone to you, Dr. Giusti?
Yes, it looks like a stone, definitely.
Have you ever seen a scenario like this where it's embedded and the stone is not easily seen?
Yes, I have seen, honestly, many times. Actually, I would say too many times. And usually it is a scenario that this endourological solution is sometimes really disappointing. Is this the case also for you or not?
So the endourological solution here, we will see. You'll see the result at the end. But we had discussed with the patient that if the stone was visible, should we go for it, even though there's a risk of stricture? And that's been the #1 concern for this case. But once we get through this, we actually will have the patient telling us their outcome, Dr. Giusti. So now more and more of the stone is seen, and we keep fragmenting and breaking up that stone. And what's amazing is great flow, because it's a 150 fiber, so good flow, no bleeding. You just don't get that with holmium, just very little bleeding. So we keep chipping away and start sculpting, because you can see that the stone had extruded to be anterior and outside that intraluminal ureter. So we kept sculpting away and chipping at the stone. And now the fluoroscopy shows less stone than what initially seen. And you can see here, there's still some stone. And so I decided we need to take more. And so we are still using the same setting, 1 joule and 2 hertz. With the thulium fiber laser, it's short pulse mode that we use because the short pulse has a peak power of 500 and the long pulse peak power is even
Dr. Gani,
smaller.
may I ask you a question? Did you try to an intact removal of the stone? Because maybe this was supposed to be better, just to be sure that you remove everything.
So that's the first time something chunky just came out. But otherwise, it was completely fused into the wall. Remember, it's been there since 2017, March, completely fused with the mucosa. So it wasn't something that would just be there and you could just pick it out. You had to chip and chip away. And then this is what the end appearance looks like. So on fluoroscopy, no more stone seen. And then we basketed a couple of the pieces, and then we placed a JJ stent at the end. The next part of the video, and this is the point where we ask, how much of this do we keep going? And this balance between risk of stricture and risk of, there's no JJ stent. I didn't put it in. So 3 weeks later, here's the video of the ureteroscopy after I removed the JJ stent. There's a little dimple there. That's the retrograde in the operating room. And now for the last few minutes, Guido, we will hear from the patient.
Thank you for allowing us to present your case at the meeting today. How did you feel when the doctors told you, and you had repeated scans and you had another procedure before, that there was no stone in your ureter that could be treated?
I felt pretty dejected. I felt like I hadn't been listened to, that my pain was not important enough, that I just was I felt depressed. I felt like I was stuck in my situation.
Why did you agree to undergo such a risky surgery where it could have failed?
I think at that point in my life, I was ready for the pain to be done, or honestly, losing a kidney at that point didn't seem a bad possibility compared to the pain that I was constantly in. When you're in that much pain all the time, I think you're willing to take more risks than you normally would.
How did you feel after the surgery that was done, that ureteroscopy?
The first week or two is always rough with the stent, but for the most part, I woke up and I almost instantly felt relief in my side. That sharp stabbing pain was gone, and I also noticed over the few weeks I wasn't getting that fibromyalgia pain that I had been diagnosed with for a couple years. I was able to get off gabapentin. I was able to get off Flexeril. I was able to get off a lot of pain medications that were making me more, sedated. So I feel like because of the surgery, I was able to get off some of these pain medicines that also made me live a better quality of life. I feel like my biggest advice to urologists who treat patients with difficult or unusual clinical situations is just to really listen to your patient. I had great doctors before Dr. Gani. They were wonderful, but I felt like I wasn't being listened to. And then when I was able to get in with you and you heard me and heard almost the desperation I had, you were willing to, I think, go a little further than other people were. I am so appreciative of that. So I just think my biggest advice is just listen to your patients, hear them, and understand where they're coming from, and understand they might be willing to undergo riskier surgeries because they're in that pain and they need that relief.
Elisa, thank you very much.
You're welcome.
So in conclusion, thulium fiber laser has low peak power. It's ideal for incision. It's hemostatic. The 150 fiber provides better irrigation. The setting I used in this particular case, and I encourage you all to consider this setting, is 1 joule and 2 hertz using short pulse. It provides gentle, small chops. I think this device will allow us a new frontier in complex endourological management if appropriately selected. And most important, listen to your patient. Thank you.
Thank you very much, Kurshir, for this wonderful talk. But now, you see, the auditorium is full, and I think that everybody is thinking, so what laser do we have to get in our department? Do we need only thulium, Soltive? Do you need also holmium? You need maybe both. What is your opinion?
I think you need both.
So you still want to have all kind of laser available?
I think in tertiary centers, most of us will have both lasers for different scenarios, different selection. I think thulium fiber laser is excellent for kidney dusting. I think holmium is probably the go-to for ureteral fragmentation. But I think thulium fiber laser is also excellent for urothelial cancer. I know we have a case coming up with that. And it also has very good uses, as you can see, for incision, calyceal diverticulum, etc.
One last question. You know, actually, we have TFL laser with peak power 500. Then we have holmium YAG laser between 2,000 and 10,000. But now we have also the pulse thulium YAG that they can reach 3,000. So what do you think about the possibility of this pulse thulium laser to become a real, I would say, middle ground in between the two?
I think it's a real possibility. I can't speak from clinical experience of using that, but from the data that we've seen, it looks attractive, and some of the feedback I've had from some of the surgeons who've used it. But I think we'll yet to find out. It's a really exciting time in endourology. I think we are at a really cool frontier where the technology, the companies are developing products to allow us to do better for our patients.
Okay, thank you very much.
Thank you.
Thank you.